And speaking of COVID and the importance also to better understand the infection, also in taking care of our patients, I'm also happy to announce the next speaker, who will be Tiziano Barbui, one of the world leading experts on myeloproliferative disorders, which are now also part of Harmony. He is a hematology professor at Bergamo, has chaired the Italian Society of Hematology, is part of the GMEMA group. I think all of you know him, and I'm happy to hear about your proposal on COVID and myeloproliferative disease. Professor Barbui.
So thank you very much for giving us the opportunity to present the results of our study on MPN and COVID-19. We addressed three questions for this study. The first was whether MPN patients are really at higher risk of death for COVID-19 in comparison with the general population. The second question we addressed was whether cytoreductive drugs should be adjusted during the COVID infection. And the third, whether thrombosis and bleeding could constitute a major concern in patients with COVID. You know that thrombosis and bleeding are part of the natural history of the MPN. So this question could be very relevant. We launched this study we called MPN COVID, and the design is a multi-center retrospective observational study. We, as a foundation for clinical research, are the promoter of this study on behalf of European Leukemia Net. But I have to say that this study was endorsed by EHA and Harmony Alliance as well. Very, very glad to present this data on behalf of these societies. As a chairman of the Working Package 9 of ELN, I am the scientific coordinator of this study, to which 38 centers participated from Spain, Italy, Germany, France, UK, and Poland. The registration of these patients started in February 15 to June 2020, and the analysis were performed in July this year. Patients were diagnosed according to WHO 2016. You see here the 4 different phenotypes of the disease: essential thrombocythemia, polycythemia, myelofibrosis, prefibrotic myelofibrosis. From Italy and Spain, these 2 countries were the major contributors of this series of patients. Remember that we collected these patients during the first wave of the pandemic, where Italy and Spain were particularly in the eye of the cyclone in this period of time. But we have also other centers, as I said, contributing for some patients in the 4 phenotypes. Of these patients, every patient had also the mutation status, the driver mutation, JAK2, CALR, MPL, and we had to not consider 3 patients who presented with acute leukemia as evolution of this disease. So at the end, this analysis pertains to 175 patients. Therapy during COVID at that time were drugs such as hydroxychloroquine, you see 60%, antiviral, 34%, experimental, and antithrombotic drugs were given mainly low molecular weight heparin that accounted for almost all patients who had treated with antithrombotic drugs. Interesting to know is that these patients were treated in regular ward or at home, or were transferred to intensive care unit in about 20% of these patients. So we had three allocation of our patient: at home, regular ward, or in intensive care units. So the first question was the mortality. You see here that overall mortality was about 28%, and you see here that 25% of patients died in the first weeks after the admission to the hospital. And then the curve reached a plateau. So the causes of death were very heterogeneous, but I want to point out that almost half of these patients died whether they had myelofibrosis. So myelofibrosis appears to be the most vulnerable disease in this cohort of patients. 48% died, especially in the first days after hospital admission. If you compare this mortality with the mortality of the general population, we found that this is a mortality 5-6-fold higher in ET, PV, and pre-PMF, and is at 10-11-fold higher when you consider only MF patients. The second question regarded whether the cytoreductive therapy should be adjusted and what was the impact of this cytoreductive therapy on mortality. These were the drugs of our patients used during the last follow-up, pre-COVID. You see two drugs were majorly represented, especially hydroxyurea was used in ET and PV in about 60% of patients. And the second drug most used was ruxolitinib. In ET, in some patients, then in PV and in myelofibrosis, particularly 60% of patients in myelofibrosis, in the 60 patients with myelofibrosis, were treated with ruxolitinib. In multivariable analysis for mortality, what we found is that age was important, sex male, respiratory support, ICU admission. But what we found that was very interesting, that ruxolitinib discontinuation was independently associated with the risk of death. You see here the odor ratio was about a 9, but the interval coefficient was particularly elevated. And the p-value, however, was very significant. So discontinuation of ruxolitinib was the major determinant to answer the question on the role of cytoreductive drug for mortality. And this is well represented in this Kaplan-Meier. This Kaplan-Meier is this curve, the highest curve, regards a patient treated with hydroxyurea mainly. And the red curve regards a patient treated also during the COVID disease with ruxolitinib. But this was the survival in green of patients who discontinued ruxolitinib. Virtually almost all patients died after 60 days if they discontinued abruptly ruxolitinib after COVID disease. You see here the slope of this curve. In 10 days, you get the most frequent mortality, and most 70% die in the first 10 days. Since this data were generated from data from univariate and multivariable analysis, to be more solid with this data, we did also a propensity score matching analysis. Of course, the number of patients were reduced to have a perfect matching with the population, but we repeated exactly the observation. As you see here, in 2 weeks, all patients died if they discontinued ruxolitinib. So the third question was about thrombosis and bleeding. What we observe in this competing cumulative risk, the incidence of thrombosis. You know that the thrombosis in this disease is 2-4-fold higher outside the COVID disease, higher than the general population. So the question was whether the incidence of thrombosis would have been higher if this patient got COVID. Really, we observed that the incidence, the cumulative incidence of thrombosis in this competing risk cumulative analysis, by taking death as a competing events, was about 8.5%. Concerning bleeding was about 5%. These rates are not so different from those registered in non-cancer or cancer patients. Multivariable analysis was done only for thrombosis because the low number of bleeding events precluded multivariable or other analysis, statistical analysis. What we found is that ET was the most susceptible disease, having a patient having a high risk in multivariable analysis independently from neutrophil lymphocyte ratio that was also independently associated with thrombosis. And of course also ICU transfer was associated independently with thrombosis. What we found a very interesting finding regards ACE and ARB's inhibitors. These were protective against the thrombosis. And as you know, there is a biological plausibility to protect the endothelium if you give ACE inhibitors, because people think that by blocking the receptor of the virus, you can reduce the property, the prothrombotic property of an endothelium that is attacked by the virus. So, in summary, mortality in MPN is elevated. Among the 4 clinical phenotypes, the risk of death was 48% in myelofibrosis. Very careful then when a patient presents with myelofibrosis. Unexpected results is the ruxolitinib, and overall mortality that is not due so much to the drug exposure, but is due to its rapid discontinuation at the COVID diagnosis. Thrombosis and bleeding is not higher than in general population. There is a protective role of ACE inhibitors. Further analysis, however, we need to study the effectiveness and safety of low molecular weight heparin in this setting. The last one, that is an important slide, is the enlargement. I have to acknowledge the European centers that enthusiastically collaborate with us. All my co-workers, these 2 people, these 2 young ladies are the biostatistician. This is Arianna Masciulli. She is the project manager for us. And of course, I have to thank very much the endorsement of EHA and Harmony, and especially European Leukemia Net. And you for listening. Thank you.
Tiziano, thank you very much for this very interesting study. And I think you raised a very important point, that it is important to continue therapy for the patients during COVID, and that we should not stop it. And you also have, of course, a very nice working environment. Congratulations.